Hello, my name is Michelle Reed, and I'm a nurse practitioner student at the University of North Georgia. And this presentation is on Marfan syndrome. Marfan syndrome is one of the more common inherited generalized degenerative disorders of the connective tissue that is primarily an autosomal dominant pattern, although there's 25% without any family history. Remember, autosomal dominant means that the patient with this has a 50% chance of passing it on to their offspring. This disorder can be seen in as many as 1 in 5,000 people, which results from a single gene mutation of the FBN1 on chromosome 15. There is no mutation in less than 10%, but instead there is another process that's present called the allele deletion. The FBN1 gene is responsible for providing the instructions to a protein known as fibrillin 1. Fibrillin 1 is a glycoprotein matrix, the main contributor to elastic fibers. This fibrillin 1 binds to others to make a thread-like filament called microfibrils. When this is not present, like in Marfan's, it causes excess growth factors to be released and elasticity to be decreased, leading to overgrowth and instability of the tissues. Since fibrillin 1 is a regulator of TGF-beta bioavailability, this leads to inflammation, fibrosis, and matrix metalloproteinase. This is the pathology behind cystic medial degeneration and wall weakening of the aorta. This, along with the decrease in collagen, reduces the integrity and leads to aneurysm dilation that is seen in Marfan's. Back in the 70s, the lifespan for an untreated patient with Marfan's was approximately 32 years. In the 90s, that since increased to 72 years, with the expectancy being lower in men and cardiovascular mortality being the leading cause. So how does the patient present to the office? Marfan presents with different severity with the earlier onset, such as those diagnosed in utero, having the worst prognosis. So the patient might start to notice that their limbs are disproportionately growing to the size of their trunk. Their chest might start having a dip or it might protrude out. They might complain of cardiovascular symptoms. They might notice some crowding with their teeth in their mouth, flat feet, increased flexibility, some stretch marks on their body, and visual disturbances or their vision getting worse. On assessment, the provider might hear a high-pitched murmur on the sternal border, optical lens displacement known as ectopia lentils, which is a hallmark sign, and possible cataracts, glaucoma, and retinal detachment. Cardiac is the primary concern in this patient population. Mitral valve prolapse is seen in 40 to 77%. Tricuspid valve prolapse and the pulmonary artery dilation are reported in about 54 to 69%. Cardiomyopathy with an increase in left ventricular size, heart failure due to volume overload from the mitral regurgitation, arrhythmias, and ultimately the aortic dissection. The provider can do a systemic score with the Ghent nosology scoring system. This scoring system, when equal to or greater than 7, indicates significant systemic involvement. This is the current accepted criteria, known as the Ghent nosology. It was defined in 1996. It's since been updated, but it came from the original version, which was known as the Berlin criteria of 1988. So the picture you see here, this patient in A, this patient has arachnodactyly. A is a positive thumb signs where the thumbnail protrudes beyond the ulnar border of the hand, and B is a positive wrist sign. The thumb and the fifth finger overlap when encircling the wrist. This, if the patient had both of these, would add 3 points to their Ghent nosology scoring system. Also with Marfan's, Emphysema changes with the bull leg can predispose patients to a pneumothorax. So, to the provider, might notice maybe some crackles due to the fibrotic process of, say, COPD. So, diagnostically, what are we looking for? We can do a skin biopsy to evaluate the microfibrils, which you can see in this picture, this first picture up on the top. This picture was done by an electron microscope. You can see normal collagen fibrils depicted as C in this picture. And there's two abnormal looking fragmented elastic fibers that are labeled as E, with the appearance of cracks and holes in the peripheries, along with numerous microfibrils. Sometimes one of the first noted signs of this genetic disorder can be these unusual atrophic patches on the patient, which can show irregularity when they are biopsied. So the next picture shows an X-ray. X-rays can be done to confirm skeletal abnormalities such as scoliosis. They have a lot of skeletal issues. The next picture is an echocardiogram. The echo is done to confirm the cardiac abnormalities, such as a valve function issue and the dimensions in order to score the aortic root dilation for the Marfan diagnostic criteria. And then last on the slide shows the DNA analysis, and this can be done to note the gene. All right, and now on to the diagnostic criteria. So the symbol above here is a free app that you can get on Apple that uses the most current Ghent nosology in diagnosing a patient. And here are the ICD codes for Marfan's and the CPT codes associated with FBN1 and TGFBR2 gene analysis for Marfan syndrome. And then below are the most current guidelines for diagnosing Marfan's. This is actually the Ghent nosology. This is the 2000 revised, which is the most current. And you can see it's broken into two different sections. One is in the absence of a family history, and then one is in the presence of a family history. And so it would have to fit in within those criteria. And you can see each one says equal Marfan syndrome. So they would have to fit within that category. You can see a lot of them are associated with that measurement, which we mentioned in the previous slide with diagnostic, how important it is with the echo, with the measurement of that aortic root dilation. All right, now on to the pharmacological management of this disease. As stated before, Marfan's can affect people differently, both as to the location and the severity. So management would be according to each patient's manifestation of this disorder. The most significant threat to someone with Marfan's is their cardiovascular system. So the primary concern for someone with this condition is to use medications prophylactically for prevention. Beta blockers have been shown to slow aortic root growth and improve survival. This would be ongoing medication to be taken. One propranolol is frequently started at 10 milligrams QID. Once again, this is dependent on each patient, but the beta blocker is the go-to med for Marfan's. Another drug that can be used is calcium antagonists for those who can't tolerate beta blockers, since they also have a vasodilator effect and negative inotropes. ACE inhibitors, which cause systemic vasodilation and reduction in the aortic stiffness. Losartan has also been shown in more recent studies to enhance the signaling of the TGFB, a link in the pathogenesis of this disorder, resulting in prevention of aortic aneurysms and partial reversal of other somatic features. And if this particular patient has issues like maybe glaucoma, there might be a beta blocker like eye drops given, like timolol, one drop into the affected eye twice a day, and we can go on with like respiratory. If they show COPD signs, you probably get a LAMA or LABA. Skeletal, some NSAIDs, but the main concern and the most threat to people with this syndrome is cardiac dissection, the aortic dissection, and beta blockers is used continuously as a prevention. So some of the education we would do for a person with Marfan's, we definitely would refer them to counseling because this is an ongoing process that is not cured. And the prevention, so ongoing prophylactic beta blockers that they will be on for life, and lifestyle changes that need to be made, whether that be diet, smoking, or anything along those lines, as far as no contact sports or anything like that. Cardiovalence surveillance, so they need to understand that it's imperative that they make their doctor's appointments and those diagnostic testing so that we keep a monitor of changes in the process, and also timing of elective and appropriate surgeries, be it skeletal, cardiovascular, their eyes. So other therapeutics that could enhance this patient population's life. A brace can help if the patient has scoliosis or the abnormal curvature due to Marfan's. The brace has also been used to stabilize the pectus for the irregularity not to progress and possibly puncture a lung. If their vision has been affected, glasses might help, and given the skeletal issues, possibly massage or manipulation could help their situation temporarily. So, as stated before, beta blockers is key to preventing further dilation of that aortic root, so compliance is vital. Keeping up with the progression is key to comparative diagnostic testing over time. We need to talk to them about isometric exercise, and competitive and contact sports should be avoided due to the risk of aortic dissection, but aerobic exercise has been shown to be beneficial. We might suggest the Mediterranean diet, avoidance of smoking, and avoidance of obesity in order to prevent increased exacerbation of the increased vascular system. And then prophylactic surgery, when if the time comes, is recommended when the diameter of the sinus of the valsalva exceeds 5.5 centimeters in an adult and 5 in a child. So who might we refer this patient out to? The patient should initially go to pretty much all of these specialties at initial diagnosis or you suspect, to get a baseline and then follow up according to that provider, unless in the case of an acute exacerbation. So we know that Marfan's affects the heart. That's the biggest concern and what really needs to be watched. So they need to see a cardiologist, and at some point probably a cardiothoracic surgeon, a dermatologist, a pulmonologist, an ophthalmologist, a psychologist, because this is something that is not cured, it's lived with, so it's probably something that they need to talk with someone about, an orthopedic surgeon, possibly, and then a genetic counselor. So follow up. Patients should follow up 6 months to a year, dependent upon this individual's circumstance, reinforcing the education that was done prior and looking for changes in the progression, repeating labs, eye exams, and diagnostic testing such as an echocardiogram. Should they become symptomatic, the frequency obviously would depend more on the situation. So, as long as things have been set, they will be following up also with the specialist. So, all right, and here's my references. I hope you enjoyed the topic. Thanks.